Welcome, everyone. This is the WBMT webinar on the challenges in achieving remission of acute myeloid leukemia and accessing transplant in resource-constrained regions. We will have 3 different talks with very prominent speakers, and they will be followed by a Q&A session, the Q&A session at the end. Would you move the next, Vera? And the next. So we'll have as our host, Dr. Cornelissen from the Erasmus University Medical Center in Rotterdam, the Netherlands, who have been working with AML for 2 decades, has been chair of the HOFON protocol in Rotterdam. He's very known. Dr. Torsten Haferlach from the Munich Leukemia Laboratory in Germany. And he also has a foundation under his name and has been working with the diagnosis of leukemia, thousands of diagnoses every year, has been very active and working with Ukraine since the beginning of the war at no cost. We're very thankful for him. And with the foundation also working with different centers in Latin America and helping with NGS diagnosis, very nice. Dr. Raul Ribeiro works at St. Jude Children's Research Hospital. Raul has been working as an outreach person for the St. Jude's in the program, and then working with Brazil and China to develop protocols for treating acute myeloid leukemia and ALL in children. He also meets with us in Brazil 2 times a week for a long time, so he's very helpful to us, has a lot of knowledge. Dr. Niederwieser, who's one of the founders of the WBMT, very active in developing BMT programs around the world, and he just moved from Leipzig to University of Pennsylvania in the US. And then for the discussion with Dr. Cornelissen, we'll have Yoshiko Atsuta, who's very nice and active in the Japanese Data Center for Transplants in Nagoya, Japan, and Aichi Medical University School of Medicine in Nagakute in Japan. So thank you all very much. So our first talk will be by Dr. Haferlach. Thank you so much. And the questions will be at the end. So please write your questions and then they'll be answered very soon. Thank you.
Yes. Good morning, good afternoon, everyone, wherever you are. It's a pleasure for me to speak first on the diagnosis, because without diagnosis, there is no treatment, and therefore I would like to take the part of diagnosis. Well, having in mind that there are different options worldwide, what really can be used, what is used, what should be used. And I know that the WHO and the ICC are asking for many different assays in AML. For sure, that would be the best case scenario, and some of the countries can deliver this, but others can't. And this is what I would like to address here, and why this may be necessary to know both of it. So as I was told before, I am part of the owner of the MLL, and with respect to diagnosis of AML, very different information is needed. Not only the diagnosis and the characterization according to the respective classifications, but also getting information on prognosis and finally risk stratification, because therapy is more and more diverse possible, even precision medicine is possible, may even get some predictive information and find some markers already at diagnosis to go for measurable residual disease. The techniques that are applicable and that are also asked for in WHO as well as in ICC are quite broad-ranged. We start with cytomorphology of peripheral blood and bone marrow. This is mandatory anyhow. This should be available everywhere and is available everywhere. The same may be true and is true for histology, so trephine biopsies that can be used for morphology as well as for immune histochemistry, as you can see here. In acute leukemias, we very often use immunophenotyping or flow or whatever you may call it. And for the risk stratification, but also for the classification according to WHO and ICC, we also need information on cytogenetics. That means chromosome banding analysis, maybe also accompanied by FISH, but especially also from molecular genetics, not only for fusion genes, but also for gene panels, as we see soon. Now, having said that, for sure, all these 6 pictures show different subtypes of AML with even more information in the pictures included. If you know what you see, for example, that this is an APL and this is the variant form of an APL, or this is an AML with an inversion 16 and others, what can be seen here in these pictures, but at least what should be clearly visible is that this is an AML. So what I said before, using peripheral blood and bone marrow smears and trephine biopsies are mandatory and worldwide available to diagnose AML. They, in some countries more, in some countries even less, because they use flow instead of this, can be accompanied by myeloperoxidase as cytochemistry or with non-specific esterase. Both techniques demonstrate that this is a myeloid disease, and this demonstrates that many of these cells have monocytic character that may be of importance for classifying according to morphology only. In some cases, there may be also information on ring sideroblasts, but this is normally only used by iron staining in MDS and not in AML. So if there is morphology, I would say MGG or Pappenheim staining, and if possible, myeloperoxidase as well as non-specific esterase should be the gold standard for the first step, and then organizing all the rest of the techniques like immunophenotyping. Both can be done quite quickly on the same day or the day after with respective antibody combinations. And then what I said before, starting with chromosome banding analysis, that means having viable cells, bringing them into cultures and looking for the karyograms, looking after metaphases first, and then bringing them to the karyograms here in translocation 1517, leading to a pMRARA fusion. And then the gene panels in NGS, more and more common use, not only looking for 1 or 2 or 3 genes, but as you can see here in our laboratory, we use all these genes in the myeloid panels in parallel in the same run in the sequencing machine. And if we know already before we start that this is a lymphoid disease, we use the other panel, the lymphoid panel, for going for NGS. With respect to classification and with respect to treatment decisions and prognostication, we started with WHO classification and the ELN guidelines in 2022. As you all know, now we have 2 classifications, WHO and ICC, and we have an updated guideline for the fit patients. And last year, we also found an updated guideline for the unfit patients, all published by Hartmut Döhner and colleagues from the ELN. We have 2 options to look into the WHO classification. First of all, the book is published in 2 parts last year, 2024. And the second option is an online format where what is organized like many WHO online formats. So you have here the hematologic cancers, then you can just press the button, go for myeloid proliferation, press the button, see all the myeloid neoplasms, including all the AML cases, press the next button, and then you see the most important information on the respective disease. You can just go onto this blue links to go to PubMed information. You found tables and figures that can be downloaded. So this is the online tool that will be updated and is updated, and the book in parallel is also possible. And as you can see here, there is still very few cases that are diagnosed according to their respective morphology that more or less follows the wording of the FAB classification, published 50 years ago first time. But these are rare cases if you just follow the respective classification. And what is also very important to diagnose AML, not only for treatment, but especially also for prognosis, is this category formerly called treatment-related or TAML or TMDS, now called PCT, post-cytotoxic therapy, that can happen in MDS, MPN overlap, or AML finally being called like this. So we have 3 different options to add the PCT. And what also would be suggested to be hopefully possible is to add the molecular information and not only the history of the patient and the morphology information, summing up finally with a diagnosis like, for example, AML, which came to a rearrangement post-cytotoxic therapy. Having said before that we start now more and more in a hierarchy by defining AML based on the genetic abnormalities. And here you see are mostly the fusion genes named, not only the chromosomes that we had before, neither the morphology. So this is a very important step-by-step hierarchy. And the first classification, not diagnosis, classification hierarchy is defining genetic abnormalities. And then we have defined by differentiation. And if we look into a cohort of more than 3,000 patients in our laboratory, we can stay here with these cases defined by genetic abnormalities in 85%, and only the rest of this, only these 15%, go to being defined by morphology and maturation. The ICC added several things, but the most important thing is that they have a different threshold for blast count, and they added a subcohort with an AML MDS overlap. So not still low blast MDS, but not still AML as it was defined before. So we have this 10 to 19% blast count and this above 20% formerly called AMLs. With respect to the diagnosis and the management, I told you before that we have several guidelines. The last from the standard treatment patients was published in 2022 by the ELN with Hartmut Döhner as the first author. And they suggest to go for the specific stuff that should always be done, like blast and differential count from peripheral blood and bone marrow aspirate and biopsy, and flow cytometry. This is the baseline, and then the respective genetic means cytogenetics, or molecular genetics means panel sequencing, or even fusion gene using a specific assay for that within, hopefully in a week. That would be best case scenario, and then do additional genes if possible. And also the medical history, as I said before, especially with respect to the question of family inborn errors or post-cytotoxic therapy. Coming up from this, we see three different subgroups: favorable, intermediate, and adverse. And if you look here on this side, no one speaks about blasts, even no one speaks about single chromosomes, but just for complex karyotypes here. But all the other definitions are based on molecular genetics. So if you want to follow these guidelines, you need to apply WHO, including molecular genetics and cytogenetics. And then you can also classify those patients according to the ELN risk score. If you only have morphology and flow, it will be different. This is the second paper for the receiving patients with less intensive therapies. And also here we have three subgroups for favorable, intermediate, and adverse. Again, here, nearly only genes or chromosomes, and the adverse subgroup is the one with the mutated TP53. I would like to add one important thing, because it's important for treatment and also for defining the need for transplant, that there may be changes from the diagnosing to the relapse. So for example, this is data from our laboratory. Those patients have been positive for FLT3 ITD at diagnosis, and at the relapse, 77% are still positive, but 23 lost this change in molecular genetics. And we have also the other way around. They were negative at diagnosis, but positive at relapse. And that's really important, that these shifts mean something for treatment decisions, for example, with respect to midostaurin. With respect to subgroups, and this is known long and still used in the ELN classifications from Hartmut Döhner 2022 and 2024, we know that we have favorable, we have intermediate, and we have adverse. And this, just one example, as you all know, is very important, for example, for APL, because then we need to be very good in morphology. We can use flow, for example, for HLA-DR being negative, to pick up those patients even before molecular genetics or chromosomes will be available, and start with the right treatment to avoid bleeding episodes and killing the patients by the wrong treatment, like 3+7. All these genes, all these chromosomes are more and more part of precision medicine, more and more lead to specific drugs like IDH1 or IDH2, gemtuzumab or zogamicin, or even GPX351 for complex karyotypes. And there are more drugs coming. I don't want to go into detail because this is not my part of the level, this talk here. Finally, there are guidelines now already published last year for those how I treat patients using azacitidine and venetoclax. So without the information on the diagnosis, without the information on the prognosis, our patients will be not best treated. However, if there's only some options possible, we need, if we want to follow up them and decide about transplant, also markers going for MRD. There are two techniques more or less quite sensitive and available, flow on one hand and PCR, qPCR on the other hand. Next generation sequencing is coming, but needs a very high coverage, and there's also digital PCR possible. Here you see the sensitivities of the respective techniques that help us for those patients who achieve remission to decide questions about transplant or no transplant, going for any further treatment or stopping treatment at that time point. This is just one example from the leukemia-associated immunophenotype at the diagnosis, 32% of leukemic cells, and during follow-up, only these very few cells for follow-up. And this can also be done with a very high sensitivity. Here are the examples of MPM1 with qPCR. Finally, this is all published in guidelines. The published guidelines from 2021 will be updated quite soon and will hopefully be published. And there is a clear table. What is the marker by phenotype or by genotype? What is suggested to use? When should it be done? And what should be the material, peripheral blood or bone marrow? So to conclude here, any approach to AML should start in any circumstances with morphology and flow. This is the minimum to diagnose this disease. All other methods should be guided by these results. We need a very quick turnaround time for APL if we want to see this on the molecular level. And what we see now more and more, not only in WHO, but also in ICC, is that the phenotypes move over to genotypes. MRD matters, especially for specification of the respective patients going to transplant or not, if you're not putting them into transplant at the beginning, after the first diagnosis. We see more and more targeted treatment. I only address midostaurin or IDH1 and IDH2. And as we all know, cure is possible with or without transplant. It is on us to diagnose and to follow up these patients on the lab side as good as we can to avoid over-treatment or under-treatment, to make all these patients best curable as they can be done based on their history, based on their status of performance, and based on the state of the biology of the AML. Thank you very much for your attention.
Thank you. Thank you very much. Dr. Ribeiro, you can share your screen. Thank you. We talked to us on treatment with low doses.
Can you see me?
Perfect. Thank you.
Good morning or good evening, anywhere. I'm a pediatric oncologist at St. Jude Children's Research Hospital, and I have dedicated my career to understand the disparity of treatment of pediatric cancer in different countries and work to improve capacity of these countries to treat pediatric cancer. I don't have any interest or conflict. And my history with AML, I started essentially with a group in China in 2012, when a physician from China came to St. Jude and explained to me that the survival of kids there with AML was about 35%. We then decided to look at the situation of that hospital and looking for things that are important for treatment of AML, including community referral, access, cost, early management, optimal supportive care, clinical diagnosis, as was described, risk classification, type of treatment, induction, abandonment, and availability of a bone marrow transplant. Any one of these points can interfere with success. So we look at that time, these were in red, the areas that were deficiency. They didn't have bone marrow transplantation in place. Abandonment was high. Access was difficult because the parents didn't have resources. And also in the community, there was a cultural barriers that the leukemia diagnosis prompt parents to refuse any treatment because they didn't want to have a child with potential deficiency. So at that time, then we decided that we would work on capacity building, and that's what we did between 2012 and 2016. And that hospital, 2 scheduled for induction chemotherapy were available. 1 using low dose, very low dose, cytarabine 10 milligrams per meter square, every 12 hours subcutaneously. The anthracycline, they had 2, one that is original from China, HCT, and they also had mitosantron, and they're using a small or half dose, and concurrent GCSF. And there were 9 physicians at the time there. Some would use standard dose chemotherapy like the MRC10, for example. During this period that we worked to improve capacity, 166 patients with pediatric AML were diagnosed before under 16 years of age. 70 patients received low-dose chemotherapy, and 96 standard. And the treatment selection was influenced by physicians' recommendations and parents' preferences. So we planned then a protocol, a uniform protocol for that hospital, looking for that at the time. And we did a retrospective analysis of the impact of induction remission on those patients and realized that the CR rate was similar between low dose and the standard dose for both first and second induction. And the hospital was very robust in terms of management at the time, so that we didn't have early mortality essentially in both arms, suggests that capacity for patients management was very good. So survival outcomes, and we saw that event-free survival and the overall survival was more or less the same as patients were treated with the low or intensive group for induction. So they received as a post-induction remission, they were treated equally, including if they had high risk and transplant was available and then was performed for both groups. We published this, but we had several criticisms at the time because it was a single institution, was retrospective, and there was no really true control. So at the time, then in 2018, we combined other institutions in the region and perform a multi-center randomized phase 3 non-inferiority trial for these kids using, again, low versus standard dose. The essentially was to compare the induction and the outcome measures. And we, between 2018, 2022, we studied 497 patients, less than the 18 years. We extend a little bit the age. 11 institutions and 246 patients received 2 courses of low-dose chemotherapy and 251 standard dose. We did enroll patients with APL, Down syndrome, secondary AML, or megakaryoblast leukemia. Complete remission was defined by morphology and recovery of the bone marrow by those parameters you can see there. And MRD was obtained by flow in a central reference laboratory. It was not used for assess response, but was used for risk classification. And the chemotherapy that we used was the low dose with mitosantron or idarubicin, and the standard dose with MRC10 with donomycin. For post-remission consolidation, cycles of chemotherapy with standard combinations for everybody. Patients with favorable receive 2 consolidation. Patients with intermediate receive a third. The patients are high risk. They were candidates for transplant. If transplant was not possible, they received a final course with cytarabine, fludarabine, G-CSF. There was no difference in age, sex, white blood cell count, CNS status, karyotype, types of mutations, risk classification between the low dose arm and the standard arm. And again, reproduced very well what we had found in a pilot retrospective. There was no difference in CR, 1 or 2. And overall event-free survival and overall survival was not inferior for patients treated with LDC. And also, we saw that there was a little bit increase of relapse among the groups that received low dose, but was not statistically significant. Also, less toxic regime based on the time to recover ANC, induction 1, induction 2, was significant shorter in patients with low dose. So where this chemotherapy with a very low dose appeared was the first report is from Japan by Yamada in 1995. And he published a small series of patients, adult patients, who had, relapse or were frail to receive chemotherapy, and combined low-dose cytarabine, aclarerubicin, and G-CSF concurrently. And he had a very good response on these 18 patients. 14 of these patients, actually, 15 patients achieved complete remission. And this study was picked up by, at that time, by Asian, particularly in China, became very popular, and they substitute aclarerubicin by their anthracycline, the HCT, to treat these patients. But others also use different forms of a lower dose of anthracycline. In 2011, there was a study, a meta-analysis, particularly in Asia, where 2,314 adult patients had been treated with AML or MDS. And the CR rate was higher in AML as MDS as expected, and also in newly diagnosed patients versus relapsed patient. This anthracycline, homohagintonin, or HCT or AGT, in the United States is called omacectacimine, but has not used here for AML, had been approved for CML, actually. And they abbreviated for HAG, and had significantly higher CR rates than in intensive chemotherapy. That's interesting that the low-dose chemotherapy in this meta-analysis had better CR rate in this population of adults, and had also a relatively low early death, and toxicity was lower than intensive chemotherapy. Some of the groups used the aclarerubicin, which is not available in the United States, and my understanding is that Holland now is trying to develop this medication. And here is the efforts between a hospital in Shanghai and the Netherlands Cancer Institute in Tong University of Shanghai, and where they are studying aclarubicin in the laboratory because it's less cardiotoxic and apparently has less toxicity, but has not been studied definitively. In this study that was recently published in Molecular Cancer, we see that in Rugin, they have several patients who were treated with different types of second-line chemotherapy. So the fit individuals received idarubicin Ara-C, and the unfit start with CAG or clararubicin Ara-C G-CSF. Those that had refractory would switch for other schedules, including venetoclax, and the patients unfit would receive 2 courses of CAG. As you can see here, patients that received second-line CAG after had failed the first line had good prognosis or relatively good prognosis, as well patients that were unfit and received 2 courses. So the information there in Asia is that this regimen that has been used for decades now is effective in AML. We wonder why this was overlooked by Europe and the United States is not very clear, but I think it's important because at the same time, more or less, azacitidine and decitabine were being developed for elderly patients with the United States with AML and without who could not tolerate intensive chemotherapy. And from this one was the next step here in the United States was venetoclax compared with low-dose cytarabine and compared with decitabine azacitidine, so that the medication, they schedule use concurrent low-dose chemotherapy with anthracycline. Low-dose anthracycline was not studied in the United States. In conclusion, I think in this randomized study that we performed, MRD rates less than 0.1% was not inferior in patients treated with low-dose chemotherapy. There is no inferiority in other outcome parameters. There is a much lower mortality. For example, in Guatemala, we use now this in Central America. We use this regimen. The mortality to the initial chemotherapy standard dropped from 25% to less than 10%. In Brazil, we about now in our protocol, I think we have now about 100 patients. And preliminarily, also the mortality has decreased substantially, and also is less cost for these countries. Thank you very much. Let me show you my collaborators in China. It's an incredible group. This is Dr. Hu. He's an adult hematologist, but she's the director of the pediatric, and she has experience in bone marrow transplant. And she came to the hospital to direct the program and then develop the bone marrow transplant. And here's the supportive care. It's very good supportive care, dedicated nurses and other supportive personnel. Thank you.
Thank you very much, Raul. If you would unshare And then you have the third talk on transplant by Dr. Niederwieser. Thank you.
So thank you very much. Also from my side, many good morning or good evening. I just want to start by a few words about the WBMT, which has been founded by Force Society more than 10 years ago as a federation of society. And all other societies joined quite quickly during the 1 year after foundation, and now we have all the society involved in stem cell transplantation and also in conventional therapy involved in this federation. What was very important was that we have the participation of the World Health Organization, as you can see here, which is needed because as a physician, we alone will not be successful as we want. So as you have heard from Torsten Haferlach in a beautiful talk, there are a lot of mutations. And here we have just one of the publication which showed that many mutations and deletions and additions are present in AML. You can see that transcriptional deregulation is we have differences, or we have FLT3, which is important for transcriptional regulation, and for transcription factors, we have deregulation and deregulation of splicing. We have difference in the epigenetics and so on. So these are just a few different examples which we know in 2015. But we also know that you can see that this is a multi-step process. As you can see here, at least in secondary AML, which is usually involving many, many months. And you can see that it's starting with CHIP, which is a status where we have already mutations which are known. These are clonal hematopoiesis of unknown potential. And then additional mutations are coming on board, and we have then MDS, and then also other mutations, additional mutations are coming. So the message of this is that there are multiple clones and subclones which are present in an AML, which are important to understand the biology of AML and also to interpret the results, especially of minimal residual disease after transplant. In the meantime, we have much more of this, as you can see from the next slide. We have, with the possibility of NGS, we have now in 2020, at the time of 2020, we have multiple molecular markers in AML, which are important not only to understand the biology, but also to make prognosis of the disease and also to possibly use as minimal residual disease. So what is very important is that this number of alterations and also type of alterations are depending on the age. You can see here in children, we have a number of alterations which are very low, but with older age, at the age of 70, you have already 10% of the population which have already alterations, which are not AML, but they are present, which children don't have. Even if you're looking at the chromosomal alteration, you have here especially chromosomal alteration of this type in infants and in children, but not in elderly patients. And you have RANKS1 and CBPF and so on in this type of patients, but in children. And focal mutations are quite different according to age. As you can see in elderly, we have much more TP53, RUNX1, NPM1, DNMT3A, IDH, and TET2 mutations than in children. So I would recommend not to use AML as one single disease, but just as a heterogeneous disease, which is important also for the prognosis and for the treatment. So the idea, which actually started already almost 70 years ago, was to replace a diseased bone marrow in adults with a good one, with a healthy one. And the first one which showed that a bone marrow can take in another individual was done by Don Thomas, and he published this in 1957. 5 patients were described, all died, but he could show that the blood group changed toward donor type of blood group. So this was the first evidence that you can replace a marrow, even if only for a short time. So the first 10 years was a disaster. You can see 203 patients were actually transplanted. Half of them did not even engraft, and half of the rest actually died of GVH, and from these 203 patients, only 3 survived. So it took many, many decades until the transplant went up to be successful. And you can see here that many specialties were working on this. I just want to mention the HLA identical, which were discovered, which were looked for, the unrelated donor registry, the immunology progress with cyclosporin, and all these things went finally up to the success of stem cell transplant around the world. And you can see that just 1 year ago, we managed to have 2 million of transplants since 1957. So what is the major indication for allogeneic stem cell transplantation? You can see it here is AML. And this is increasing quite rapidly. And fortunately enough, the AML in first complete remission is the highest indication worldwide. So AML in second, in non in first complete remission, or in, later than 1 complete remission, is the second most frequent. And then we have other diseases like MDS, MPN, and of course also ALL. So this is the most important indication for malignancy. And the question is, what is going to be the paragonator? What is the results of non-stem cell transplant? And you can see this here in a publication which is done by the Osho, where we published 1,600 patients which were entered in the Osho studies. And I think what is very important is that there is a bias, especially in elderly patients, because some of them were excluded from treatment because they were too sick, they were unfit, and so on. And by looking at this data, you can see here that we have in patients over the age of 60, the results are less favorable than patients with the age of 60 or under the age of 60. This was not dependent in this studies about complete remission after first or second complete induction. So, and only a few of them actually received stem cell transplant, and this is lasting more than 12 years now. Even if you have a partial remission and you are younger, you have a chance to be cured in a lower percentage of patients. Of course, if you are older, we have a problem here, which the disease, the overall survival is going down quite quickly. And if you're not responding, it's even worse. So the question is, what is the problem? Why the results in over the age of 60 or below the age of 60 are so dismal. You can see it from this slide. The major problem is the relapse. And you can see here that the younger patients have a relapse of 40% and the older patients have a relapse incidence of 60 or 70% in this population. And we have 10 to 15% of non-relapse mortality. So we did a study. It's the only randomized study together with Hofmann, Sack, and Osho. And you can see here that patients in CR1 have even 90%, which are over the age of 60, have 90% of relapse. And the only way to reduce this today is stem cell transplant, even in elderly patients. So you can see that from 90%, we have here 30% of relapse, and that's the only way how, at the moment, how we can reduce the relapse. And this is also resulting in better leukemia-free survival with transplant than without transplant. If you're looking at patients which relapsing after chemotherapy or even after stem cell transplant, the only way you can have more a respectable way of overall survival is by doing transplant. Also, donor lymphocyte infusion are not as effective as a second transplant or a first transplant after relapse, and also other intensive chemotherapy, hypomethylating agents, and so on, are not successful. So how we improved actually, or how can we improve the stem cell transplant outcome? So one way is certainly that we improved the non-relapse mortality. Here you can see the patients which are transplanted in Leipzig, and you can see that we reduced the non-relapse mortality from 32% to 7% during the time between 2009 and 2014 in respect to 1980 and 2002. So this is very important. We have a learning effect here, and everybody which actually should or want to start a new transplant unit should think about this and adopt protocols which are according to SOPs and even collaborate with centers which are JC accredited. The second problem with the stem cell transplant was the age. You can see here aging is increasing. In the year 2050, more than 15% of the whole population will be over the age of 65. And even more, the problem in AML is that the majority actually of patients with AML are older. So until 20 years ago, we just treated this kind of patient, and we couldn't actually have this type of patient. So there was a wavefront in the 1990s where we started the reduced intensity conditioning or the non-myeloablative conditioning to reduce the toxicity, and there was still considerable effectivity in the non-relapse mortality. And you can see here, we have, if you're talking about reduced intensity conditioning, this is not the same. We have here minimal pancytopenia, short pancytopenia, long and irreversible pancytopenia. So there are here clear classification on how to name that. And for older patients, we are using usually non-myeloablative conditioning with 200 TVI up to the age of 75 and today even up to the age of 80. And this was quite successful by using reduced intensity conditioning or non-myeloablative conditioning. You can see that the proportion of patients over the age of 60 increased considerably during these years. So the other important point was that we had not enough donors available, even if the unrelated donor registry were very, very effective, and we have several millions of donors. And this was actually pioneered by Lutznik, which showed that by using a post-Cy regimen, you can kill the alloreactive T cells and make haploidentical transplants, so use haploidentical transplants with a similar outcome, even if we have more virus infection after haploidentical transplant. So this is another milestone in the development of stem cell transplant. And finally, also the impact of measurable residual disease will have a big impact, and that's the reason why we need molecular typing and also quantitative molecular typing. You can see that patients which are negative before transplant and negative after transplant have the best survival. Patients which are positive are also before transplant are also, depending on the results after transplant, about MRD. But don't forget, MRD is just looking at one molecular marker. And if we have subclones, this marker can change. So this should be taken with prudence, even to tailor the treatment. But what is very important is also that you need a marker to see how effective a treatment is before transplant. And perhaps with the low intensity regimens which we have available today, we have much more MRD negative patients before transplant. So what about the access to transplant? As you know, the World Health Organization is very effective in supporting this, that there is an equitable access to transplantation around the world. And the question is that the case? And the answer is no. So you can see in North America, we have here for allogeneic transplant, 227 allogeneic transplants per 10 million. So this is normalized for population. And if we are comparing this with Latin America, or with EMRO, or with Africa, or even with Asia Pacific, here we have huge differences. And this is one of the topics which in the WBMT we are following, look how we can improve this, these numbers here. And also there is a huge difference in a number of transplant centers, transplants per transplant center, and also about the teams per 10 million inhabitants. So you can see that Europe and Asia Pacific are doing less transplant per team, but have many transplant teams. North America has lower numbers of transplant centers, but have higher transplants per team. And I think that's something where we can optimize around the world. How we can even increase more the access to transplant? There are many points here which are important. Social, demographics, donor type, economics, healthcare systems. The WBMT cannot intervene in all of them, but can intervene in some of them together with the WHO. And one of the most important points is the Global Activity Survey, which is now electronic, and where the people can enter their activity in 1 year. And we have now a reporting of 1,800 transplant centers around the world which are reporting. And I can tell you with big happiness that in 2021, we have now more than 100,000 transplants a year. And this is still increasing. So there is no plateau yet. Then the next point is the workshops, telemedicine, developing global codes about ethical issue, promoting global good practice in relation to quality and safety and the accreditation and standards. So by looking at how we can improve this more in detail, we have distinguished between starting new programs and optimizing existing programs. And for each of them, we have published some recommendations. Not only the biannual survey, we have the organization of workshops, we have essential medication, we have the training of physicians, how this should be done, infrastructure, site visits for experienced physicians, financial aspects, trainings, and telemedicine. And for optimizing, we have now outcome registry to be planned, accreditation, and again, looking at utilization of stem cell transplant worldwide. And utilization is one of the points which I want to show you here. Here we compared the incidence of AML and the percentage of transplants. This has been published in WBMT 2023. And you can see that there are countries or regions which have even lower than 10% of patients which are transplanted with AML in comparison to Northern America or Europe, which have in between 20 and 30%. I mentioned the symposium. The next symposium will be in Mongolia. These are now important issues because this is making the politicians susceptible to stem cell transplant. So this will be in June in this year. And the most important point is telemedicine. You can see it here that we recommend that the physicians will be trained in a JC accredited stem cell transplant, establishment of core facilities here in Lithuania, for example, site visit to the facilities from our point, selection of local experienced hepatological staff, and start the program. And you can see that with a TIM of only 1.4%, we managed to have a new transplant center. We did similar in Latin America. You can see here before the telemedicine and after the telemedicine. These were just autologous patients. Here were autologous and allogeneic. You can see that these were non-relapse mortality was 0 in this few patients, but still that was important. And what we realized is that now that we can make transplants, we don't have the patients which are put in complete remission. Here, you can see in Latin America, we had the problem that these patients that didn't not even reach transplant because they died during the induction chemotherapy. When we started then to adopt protocols and treat them even in transplant, in the transplant floor, the overall survival was much better. Another point which is important is even during a war, we were able to help to establish stem cell transplant programs. And you can see here, this is an effort of all the societies in the world, which helped the Ukrainian people to make an essential drug and supply list and provided also the medications. The tumor board was done for difficult patients, the allocation of pediatric and adult patients in and outside Ukraine. SOP were provided for stem cell transplant. We had to establish an unrelated donor registry. And you can see that was already mentioned that standard diagnostic and treatment option in the country. All the patients with hematological diseases are analyzed in Munich at no cost. And the people there didn't just not realize what they have, and they were wondering what kind of information we can get and how they can be used. And they have one transplant society. And so this is something that even in countries which are very, very stressed by whatever, we can establish this. So in summary, continuous increase in stem cell transplant activities worldwide, increase in specific indication in haploid integral transplant by new techniques, improved access to stem cell transplant in specific world regions, and gaps narrow between regions but still remain. So this is a work of many, many countries, societies, and people, dedicated people, which actually are helping in doing this. Thank you so much.
Excellent, thank you. Dr. Cornelissen.
Well, first of all, thank you. Adriana. I would like to thank the speakers for their excellent presentations, very clear and helpful for this interesting topic. I would like to invite the audience from all over the world to ask questions. We didn't see any questions already emerging in the Q&A, but please feel free, if you have a question, then I will allow you and you can approach one of the speakers. We have a approximately 10-15 minutes session for these questions, which will be done by Dr. Atsuta and myself. And if I may kick off the first question for Dr. Niederwieser, who just presented his findings and his experience with the Worldwide Network. Dr. Niederwieser, can you explain to us also, given your experience with the Mongolian Center, how regions worldwide who would like to start and to develop a center, what are the crucial steps to be undertaken, and how you and your network can be instrumental?
Now I can hear you again. Yeah.
So, should I repeat the question?
Please, yes, shortly.
Yes. So, given your experience in the Mongolian Center, Kaukus, could you please indicate, and this might be of value for regions worldwide, when you want to start a transplant center, and how can the Worldwide Network help in different ways, apart from science and knowledge, but also in terms of training and people and finances and so on? What is your experience, and how should these centers take these steps one by one?
Yeah, so usually until now it was that the centers contacted either ELN or WBMT asking to make transplants and to be helped to make transplants. So that was the first one, was in Hanoi more than 12 years ago. They had 6 transplants in the whole country in 1 year. So we asked to make an application to the WBMT and to tell us how big is the hematology and how many AML they have, and even if they don't have AML, non-malignant diseases like sickle cell anemia and so on. So this is the first step, a request to the WBMT. We have now a request from for Ethiopia, which came through Mikiko from the Ministry of Health. So this is another way. Not only doctors are asking, also ministries are asking to help to set up this treatment. So then somebody has to evaluate this center. We are not starting from nothing. So there must be a hematology there, and also, of course, diagnostics should be there, and the possibility to have drugs enough. And we have this essential medication paper, which is used now also for these countries to license the drugs in these countries. So this is the next step. And then if we understand that the people there are committed to this, and the hospital general manager is in favor of this, because without them it would not work, and the politicians are supporting this, then we are starting to work with them, and even if they want this, to have telemedicine on a daily round. So that's the sequence, and usually it works if they really want to do it. If we are feeling that this is not enough, we will not start this.
Okay, thanks very much. And next to that, because that's preceding access to transplantation, it's access to diagnostics and to the type of chemotherapy Dr. Ribeiro has outlined. So maybe Torsten and Raul can follow up on that. First of all, do you cooperate with the organization as the WBMT? And how are your initiatives of providing these kind of insights to centers who would like to develop AML diagnostics, AML therapy, and subsequent also transplantation in, well, so-called underdeveloped countries or countries who have so far had insufficient access to diagnostics and therapy? Maybe first Torsten and then Raul can answer.
I can give you two examples from our side. So we work now since more than 5 years together with 6 laboratories in South America, and with the help of Ash and Illumina, and especially my foundation and Peter Falk in the Netherlands, we installed 6 laboratories for NGS with sequencing machines and with assays and training. And Peter Falk's team trained these colleagues in the laboratories all over there and also supervised them. And we paid the machines and the maintenance and the consumables, and therefore they were able to add molecular genetics using NGS to their routine workflows for all these patients with AML. The other example is with Ukraine, and Dietger Niederwieser organized that together with us. We are now on the way that as far as we do all the samples in our laboratory, we help those colleagues in the land, hopefully with peace soon, to build up their own laboratory. We already exchanged a list of machines and assays and workflows where this could be done, and then we expect to train those team over there and vice versa to make them able to do what we do for the respective techniques. That starts with morphology, that follows by flow, but this will even include genetics and molecular genetics, and this will hopefully start soon in the land and together with us, the Ukraine laboratories. And there will be one laboratory dedicated to do this together with us in the Ukraine for the complete Ukraine.
Thanks very much.
Thank you for the opportunity to discuss the issue of bone marrow transplants in countries with limited resources. So, you know, there is an incredible difference in capacity in different countries. For example, in Chile, they had reached very good patient care, and the survival of ALL was more than 80%, and AML was low. So at that point, we partnered with the hospital in Chile and with Pasquini in Curitiba, training the people, and Rupert Handegreeder, now in Frankfurt, I think in Frankfurt now, and he was at St. Jude. He trained the people who were trained here at St. Jude, nurses, and the physician, Julia Palma, who was the main director. And now they have a transplant capability for Chile. So this is one idea how to regionally developing bone marrow units using available capacity in the region. For example, in Central America, the only country with bone marrow transplant is Costa Rica. All the other countries, including Guatemala, Nicaragua, El Salvador, Honduras, don't have bone marrow transplants. So in that case, we are working with a group in Italy from Monza. a person there has developed bone marrow transplants in Iran, and she is now developing capability in Guatemala first. And our idea is to develop first in Guatemala and from there to other countries in Central America. We are not affiliated with the WBMT, and I have to confess, I didn't know that there was this possibility, and I work with Adriana and other individuals in Brazil, but I didn't know of the mission of the WBTM was to improve capacity in countries with limited resources as well.
Okay, thank you very much. I hand over now to Yoshiko Atsuta, who will guide the second part of the discussion. Thank you very much.
Thank you, Dr. Cornelissen. There's one small question to Dr. Niederwieser in the chat, and it is regarding the data you reported on the WBMT experience in Latin America. Since it is a highly heterogeneous region, to which countries were you referring to? That was the question from the audience. Dr. Niederwieser, you're muted.
Mute.
Thank you for this very important question. I think that this is one of the best achievements of the WBMT was to found the LABMT and provide help in establishing a registry. Today, the LABMT is ahead of time because they are collecting all the transplants at most of them actually at the center level, and they have an electronic tool to collect them, and this is given even to the country. So they have a country registry which is providing the data to the LABMT and also to the worldwide blood and marrow transplantation. And what is even more important is that they are the first one which are collecting all the data in the region for pediatric patients. But Adriana, you can say this better than I can say that. And for Africa, we are now working hard to put the people together.
Thank you so much, Yoshiko. I'm sorry we are on the hour. So if you don't mind, I just want to thank all the speakers, thank everyone for their work and for helping out with other countries. And the talks will be were recorded and be on the WBMT website. So I thank everyone.
Adriana, can I interrupt you for a second? There is one important question. How to preserve the blood to send it for diagnostics? And Torsten,
my question.
Perhaps can answer this quickly.
All assays can be run within 48 hours. So if it's available within 1 or latest 2 days, even chromosomes will work. We have the experience in thousands of cases, and this is what I can tell you. This is also true for the samples from the Ukraine, for example.
Yeah, Dr. Haferlach, I made this question because Brazil is too large and samples may take like a week to get to the site.
Yeah, that's then it works only some kind of assays, but 2 days, 48 hours, that is what you have to achieve.
All right, thank you. Dr. Cornelissen, you have a hand raised, and then if you can please finish. Thank you.
Yeah, so I'm a bit bold, but I would like to challenge Dr. Haferlach. You have so many samples studied so far, and currently we are developing artificial intelligence all over the world, and probably you are doing it yourself. Can we expect a much more simpler and direct tool for diagnosing and classifying AML in the near future which might also be of use, especially be of use for these developing centers.
Yeah, I fully agree with this, and we use AI in all our parts of the laboratory, including morphology readings, differentials, chromosomes, as well as molecular. And we even use them to write the reports before humans start to work on the reports or the other readouts. And these assays will then be applicable not only in our laboratory, but also in others. But the machine has to be there. But the readout of the machine and the reporting can be done by AI support. And this will happen in the next 5 years, I'm sure. That will really make it much more flexible. Like the iPhone is more flexible for every country. All these assays using AI in the workflows in leukemia diagnostics will also be very helpful in the future. Next 5 years will be my prediction.
Wonderful. Thank you very much. And if you have other burning questions, you can email us to WBMT and we'll forward for the speakers. Thank you so much. Have you all a good day, afternoon, and evening. Thank you.
Thank you. Bye-bye.
Thank you.
Thank you.